the market share of AI, in particular in medical imaging. And you will see the compound growth factor is ginormous. It's projected to be above 30% every year after year. And when we look at the contribution to radiology, you will see that radiology is the biggest piece of the pie. So why are we not using it every day? We should be seeing it left, right, and center, and we don't. There seems to be a gap between the market share, the growth, the investment into the sector in medical imaging, and what all of us here are using on a day-to-day basis. And that is an interesting factor. We may have to understand what holds us back of using more of this technology, and we have seen these beautiful examples this morning. Now, when it comes to workflow, you would argue this is the easiest thing we can do. We don't have to go into image analysis, in detecting nodules, automatically segmenting, even giving us a final diagnosis. Maybe we just do workflow, first thing. And that's what we did. We just said there's a stupid task we all have to do. It was alluded this morning to already. When we have to go through all the requests, I think you and Franz do it differently, and then have to protocol. That's stupid, right? I mean, we know what's going to come. We practically look at the indication. Often it says, rule out, and then it's empty. And so what we did is we just trained a system internally with 210,000 requests and then let it run. And it always gave us an answer. But the problem is, you may argue, is that really good enough? 84% of accuracy? But that's only half the truth. The truth is, the blue bar is the AI, the red bar is the human. So the problem is, we don't even agree on a protocol. Our faculty, they have different opinions. And what is the AI supposed to do? Learning the failure, learning the discrepancy, and it will repeat what has been done in the past. And learning from the past is one of the key features that we need to consider when we employ AI. Let me go back in time and understand that we are not doing anything new today that hasn't been done hundreds of years ago. For a long period of time, in the Industrial Revolution, steam was the main source of power. And the whole infrastructure was designed around steam. Factories were designed in a vertical way because you had a steam engine and you couldn't afford distributing the steam to a remote location. What I'm trying to express here is the whole system was built around the predominant energy source. And it took some time after the discovery of electricity that the first factory was using electricity. It makes perfect sense. Smaller and predominantly cheaper. Cheaper. The price point is lower. But it then, surprisingly, took 40 years to make that happen, that electricity is the main source of power. And there is a question, why is that the case? Why the obvious took so long to be implemented into the manufacturing processes? And there's an explanation for that. There's always setup costs. Changing from steam to electricity is not for free. New equipment, new installations, new power lines. Copper wasn't so cheap at this time point, so there's setup costs. There was a lack of skilled HR in new field. They couldn't find people who have the knowledge. And there's certainly ergophobia, which is just a sophisticated name for people who are worried about losing their job. And when you think about, isn't that exactly what we hear today for AI? The same concerns and the same barriers we see today that happened hundreds of years ago on such an obvious thing, and we could not even think differently today because we're all using electricity. But what if we change the system? What if we now decentralize the power lines? We are now seeing we are able to put factories outside of the crowded city. And there's many advantages of this. And suddenly the value of electricity is completely different. And that was the breakthrough, why it happened. Not so much because it's cheaper, because now we have new products, can provide new services, we have new skills, and also we created new jobs. And again, what I'm trying to say here is that any different today with AI? No, AI, the term goes back to the 50s. And there was a workshop, a 4 weeks workshop, and the creme de la creme met, and they were philosophizing around what could artificial intelligence potentially be. That's the first time that we have a record of the term artificial intelligence. But it was mostly for many years driven by military investments, intelligence services. And in particular in the US, they were so interested in having a speedy online translation of Russian communication in the Cold War into English and then back to understand what's going on. The problem only was, and this is a famous quote, they translated "the spirit is willing, but the flesh is weak." Translated it to Russian, back into English, and what came out, "the vodka is good, but the meat is rotten." And they understood this is not what we really want. There is a fundamental problem, and many of those things happened later on. The Lisp machines kind of died, and many generations of computer inventions and innovations actually failed completely until there was machine learning becoming a mature technology. The multi-layer neural networks were kind of the breakthrough for this kind of artificial technology that now can take tasks that were performed in the past and predict the future. You all use the same thing. When you interview, and some of you are in committees, and when you try to get a new resident, a new staff member, whatever, you ask a conflict resolution question. Always, I would assume. But technically what you're doing, you're asking for someone to say what would happen in the past, and you predict based on that information the future. Under certain conditions, this would be okay. Well, it needs to be the same person. The person shouldn't have learned anything in the past, right? Otherwise, it doesn't apply. Then it needs to be a very similar, if not the same situation, which is problematic. And there is a huge risk of bias and prejudice in this process, but we all do it. So why could we expect AI does anything different? And this is the reason why today, in many of the blogs, you see tons of them on social media, there's almost a fear, a crisis of AI. We will have no meaning anymore in the future. We have no privacy. Our jobs are taken away. And you know, some political streams actually utilizing it for different purposes. But why don't we focus on the big opportunity, which we may or may not see yet? And that's the big question. And here is one of which. This is a true CT obtained with conventional filter back projection on a very low dose setting, as you can see, 0.5 millimeter slice. It's not diagnostic, right? There's nothing you can actually derive other than it's probably through the upper abdomen and there's probably a liver on it. And then there's this magic button. And if you press the magic button, what's happening is the scan gets better and better and better. And suddenly you have an image where you think you have diagnostic information, but hang on a second. How do you know? How do we know from this image before, which is the source image? It's not the raw data. You can't look at them, not yet. We're not intelligent enough. But that's from the source image that literally had no diagnostic information. Do we believe that? It's called deep learning. But what did the system learn? The law faculty in Stanford, they provided a list of 37 reasons and concerns and principles in AI. It goes from transparency, and there's a long list here. You can see reliability, relevant R&D, privacy, fundamental rights, human rights, equity, and so on. But I thought, let's not go too far. Let's pick the 3 most important things that AI should do. And that is, it should be accurate. We should, in medical imaging, get a picture that tells the truth. We want the next time we do it, getting the same result, which means it should be reliable. And we want to understand what AI does. If we don't, we may not gain trust. Now, CT is pretty trustworthy. We have been using it for so many years. We know, you see the little hip absorption here, you can actually understand in the sinogram where it's going. We understand what's going on. And when we take these images then, these sinograms, and back project them into space, that's a linear process. I understand. You may not know what this formula means. This is filter back projection, that is iterative reconstruction with a cost function. But we understand, mathematicians know what we're doing. But when we take this picture now, we use AI, deep learning, and the picture is inaccurate because it can never reflect the truth. There's loss of resolution. We talked about this morning. And what we get now, is it a true picture or is it a probability map? Do we have to accept the picture we are getting now is not what has been measured? it's what a system has thought is probably true. But how probable is probable? We don't know. Look at this example. The image looks okay. It's probably a standard picture you are used to. And we know it's not accurate, it can never be, there's always a loss, but it's reliable and explainable because we can reproduce the very same picture tomorrow under the same conditions. And then we use AI, we get a much better picture. Clean, no noise, new structure. Well, I would argue, well, it's still not accurate. How could it? But is it reliable? Will we get the next time exactly the same picture? I don't know. I don't know that anyone knows. And is it explainable? Do we understand? How did the AI arrive at this picture? And is it actually showing the truth? I was last weekend on Thanksgiving here in Canada. I know the US a little later, but friends of ours have a farm. Beautiful. I came in and like the sun came out, nice, the turkey kind of prepared it and everything, butter under the skin, you know what I mean, right? And I took that picture, except I was overexcited. The horizon is not straight. So I thought, okay, let me correct that. The problem is, you have to make the picture smaller, right? I mean, you can't, there's missing information. But what if I fill it in? It's a perfect picture now. Just doesn't reflect reality. But how do I know? I can zoom it up for you, you can come in front, you wouldn't see a difference. It looks like a perfect picture. And then I thought, you know, the only thing, these ugly little sheds here, let me get rid of them and just replace a little tree here. And the point I'm trying to make is, you understand what I did. It's not even big science. You can use it on your phone. But what if we didn't have the original anymore? And I heard this morning, many centers don't even use a regular reconstruction anymore. They only use deep learning, and that's it. But how do you know? How do we know it reflects the truth? Here's an example. Look at this. Low dose, nice calcium score. Perfect, you can think easy. How do we know? Maybe it was that shape. Or maybe it wasn't there at all, and AI made it up. If you don't have high-dose images and don't have regular reconstructions anymore, how would we know? We need to trust Jens 100% that these calcifications are actually true. And I don't know if we are at the stage to do so. Maybe we are. We can make up stuff, and making up stuff is actually good. This is an application of AI where we want to use radiomics in brain tumors and get specific characteristics and classify those tumors. But circling a tumor in the brain is a tedious work. So instead what we do is we just use generative networks. They make up stuff. We take the tumor out and just generate normal tissue in the area of the disease. Why would we do that? Because if you subtract those images, the only thing you get is the tumor. That's the residual. And then we can apply all the tools we have, radiomics and other features, and can work on it without any manual segmentation, self-learning, so to speak. We did the same in chest X-ray, because there was a time, remember, when COVID hit, we had X-rays, but not enough to train an algorithm. We have millions of X-rays for pneumonia and everything, but not COVID. And when you apply the same system that you can generate normal images, you can generate diseased images, although the system has never seen COVID, we generated a system that detected COVID with an AUC of 77%, better than anything published before, on generative networks. And that's the power I wanted to allude to you. It's not nonsense, but it may help us accelerate research, and the system may create something that it has never seen before, self-learning. We talked about deep learning in the reconstruction already, and the good thing about what Canon has, and there's a huge advantage, Canon has a phenomenal machine, the Precision. And the Precision machine gives you thinner slices, 2K resolution potentially. And now what the researchers did, they used that raw data set, destroyed the image intentionally, but it's perfectly registered, and let an AI understand, let me go back to the original quality. I know what the truth is. I don't need a label. I don't need a human. I know what the truth is, and let the AI figure out coming from bad to good again. And that's the deep convolutional network. That's what it does. A bad image now, transforming it into a good image. But hang on a second, based on which information? The information it's creating is not in the original image. It's a lower resolution image, no matter what. And it makes a beautiful picture. And the pictures are really good. Look at this picture here. This is a standard reconstruction. And I always wonder, what would radiologists do, chest radiologists, if we would take away the expression ground glass? They would die, right? Everything is ground glass. And what it technically says is we don't know what it is. Our resolution is not good enough. But what if the eye resolves the resolution? Or should I say pretends to resolve? Because look, there's certainly some bronchi. There is texture in it that we haven't been able to see. Maybe it was in there. Maybe we were not well trained enough to see it. But at least we should ask that question. Look at this beautiful picture on this side here, the AI. But yes, we have the comparison because we can still reconstruct. But think about what in the future if we don't have the original image anymore. And a nice group from the NIH did an experiment. They wanted to know, does deep learning impact quantification? Not only seeing it, anatomy, structure in the lung and chest, does it actually change Hounsfield units when we rely on them, such as in coronary artery calcifications? They applied deep learning, but still had the original, and then compared. And they found, not surprisingly, well, it doesn't really matter. There were only a few patients that had to be recategorized based on the risk factor, but the kappa was almost perfect. Okay, let's do it. There's no concern anymore. And what happens if we push the boundary now? If it's so good and noise is gone, why don't we drop the dose dramatically and see what happens? You have heard this morning already the silver beam, which is just 0.5 millimeters silver in front of the tube, take out all the soft beams, which only create radiation dose, don't contribute much to the picture, and we have a much better scan. Sure enough, that's possible. Look at this. This is the regular one. Normal reconstruction, peak reconstruction, beautiful picture. But now let's drop the dose down to almost nothing, and I'll show you how little that is. It's actually 0.06 millisieverts. We still get a result. Now you may trust and say, yeah, sure, because I have the high dose image or standard dose image. But what if you don't have that anymore? What if you can't compare to the truth? And then the next step, and now I'm bringing back my initial thought. What if we create a new system, making it better, more beautiful, lower noise, a little more structure is all fine, but we're still in our same system. We haven't touched anything. It's just a gradual improvement. What if we become a little more radical and do exactly what should have happened in the Industrial Revolution when electricity was in the mix? All right, we have chest radiologists in the room. Is that a good test? Is chest X-ray a good test? It's a serious question. The sensitivity for detecting pneumonia and smaller lesions is 43%, less than flipping a coin. And the positive predictive value is 26%. Okay, now seriously. In 2024, we offer a test 300 times per day at UHN where the predictive value, positive predictive value is 26%. Is that appropriate? Should we use any AI to improve it, or should we just say, we're at the end of it? After 130, 140 years of this groundbreaking, world-changing discovery of X-ray, is there time to change? Well, I'll give you an example. That's an X-ray. And Narinder, you're board certified?
2 boards.
2 boards. Okay. Do you see the cancer?
1 for each lung.
Do you see the cancer?
Yeah, I've seen this before.
Okay. All right. Okay. Well, it's good. But Narinder, remember, a broken clock also hits the right time once in a while, right? You know that, right? Okay. So, yes, of course, you can argue wrong indication. Why would you do an X-ray if you're looking for mediastinal paraganglioma in this case? Well, let's take that case. Narinder, again, second chance. No, it's the afternoon.
I've seen this one before.
No, it's PM, right? Still the same time, right? Exactly. So, but look at this. A 3-centimeter cancer. And this has nothing to do with AI. It's just a regular case from operations, day-to-day operations. Isn't that scary? Isn't that scary? And we're still offering the test, maybe for the wrong indication, but we still do. You understand why that's the case, right? It's overlying the first rib. But still, that's a huge issue. And is this the time to think about something? Maybe we should replace it with low-dose CT. And there are a number of publications that say we're getting close to the X-ray dose when we're using ultra-low-dose CT, in particular when we have now the silver beam. You know, Princess Margaret about 10 years ago had a big banner, right, for donors, and saying, we will eliminate and conquer cancer in our lifetime. They didn't say when, but they say in our lifetime, right? I transferred this into, we will eliminate plain films in our lifetime. And I have to confess, We did eliminate plain films for the abdomen, because really, I have to tell you publicly, you can cite me, abdominal plain film shouldn't be done anymore these days. This is a nonsense test with practically no diagnostic value these days. All right, but chest is different. It's portable, there's universal knowledge, it really doesn't cost much, right? Everybody believes that he or she is knowledgeable and can interpret the images. So why would we change that? The problem also is, when you replace X-ray with CT, we alluded to this in the morning, you're getting 500 slices. Who on earth can use an office PC and download 500 slices, scroll through and say, oh, you know what, maybe there's an pneumonia now. Impossible. So we took on that task and developed a presentation technique purely for presentation to make sure you don't have, as a radiologist, to go through 500 slices. It condenses the information. Well, if we didn't use deep learning, just the old-fashioned iterative reconstruction, that's what it looks like. That's not a diagnostic scan. But if we base this on AI, these images become diagnostic. They look X-ray-ish. They're not X-ray, X-ray-ish. But look at the power of this technology. This is dose parity, the same radiation dose, the same. The DAP on one side, DLP on the other side, converted, allowing for some uncertainty of 30%, that's the same dose. And even with knowledge where the cancer is, you wouldn't find it. Look at this one. Even knowing where it is, you wouldn't find it on X-ray. Same dose, just a CT instead of X-ray. Here you see it, but again, I'm trying to make the point, there's so much more we can identify on ultra-low dose CT, which is impossible to understand or to see on X-ray. And the last thing I want to tell you is, now we took that on and said, let's make the bold step. Let's see if we can replace plain film with CT and drop the dose using all tools we have, silver beam, deep learning, dropping the dose. And reality is we can. We're presenting our results at RSNA, and the answer is yes, it's possible. It's standardized for a 75 kilogram human because X-ray dose goes up when the person is bigger, so does CT. But if you standardize it per kilogram, you get even less dose than a regular X-ray. Don't get angry at me, okay? I'm summarizing now, okay? Just letting you know. Okay, so in summary, I show to you the aggregated growth of AI in medical field is enormous. It makes absolutely no sense to fight it. If we fight it, we are out. We have to embrace the technology. It will make our life easier, but it has consequences. And I try to allude to some of the fears and the concerns that are expressed in our society for very valid reasons. And we can't ignore this when we use AI in our daily practice in medicine and pretend it's all fine. We have to be very careful. AI will change the workflow. There's no doubt. And I wanted to show to you is that time to make a radical change rather than just improving what we're doing and then say, well, it's a little bit better, a little bit more accurate, a little bit lower noise, great images. But is that the true impact AI can have? I wanted to make sure that we all remember the three core pillars, and that is accuracy of anything we do, reliability, and explainability. If any company comes to me and says a beautiful tool, but I don't even know what they do, I'm not sure I would take it. The generative adversarial networks is the future. They have so much potential. It's not about the AlphaGo experiment that Google did, and when suddenly Google was better than any player in the world, but that shows you where the potential is. We will see in an era in which AI is so good, you don't have to teach the AI to do the job you want the AI to do. But in my view today, the true killer application in medical imaging is deep learning reconstruction, both for CT and MRI. Thank you.